All right, so welcome again. This is our last video for the book club reading. And we have with us here the author, which is really exciting. We have Gerard Boychuk. Thanks for joining us.
Well, thank you very much for having me, and thanks for choosing my book for your book club.
Yeah, we've really liked it. It's amazing that all of us who work in this movement to try and win universal healthcare in the United States, we all sort of learn different explanations for why we don't have it so far. It's part of our sort of internal movement history. And yet it's very rare for people to look at the role of the politics of race, which is kind of shocking in retrospect, since it's such a clear, major element of the history of the country. So thanks for having done it.
Right.
Yeah. So let me just start off with a question. So the first question is, what is the current status of national health insurance in Canada with regard to services covered?
Well, really in Canada, not much has changed since the program was consolidated in the mid-1980s. And so it really is a bit of a frozen landscape in that the range of services covered is pretty much the same as what it was. And that is, basically the Canadian system can be described as narrow but deep. And that is the universal public health insurance covers hospital care and physician care. And then there's a range of areas outside there that people would normally think of health services or health-related expenditures that aren't covered, or maybe covered by particular provincial governments, such as pharmaceuticals or other areas like that. No major areas have been delisted. That is, there hasn't been a radical contraction in the range of services that are publicly insured, and there hasn't been a major expansion. I mean, at one time it looked like there would be expansions to home care. It looked like there would be expansions to pharmaceuticals. Those kinds of things have been on the radar over about the past 15 years. And then there was a period sort of after that expansionary period where it really looked like there were, people anticipated, I think, some major political challenges to the system. And those sort of withered away too. So there wasn't major retractions in the way that we might have, I was writing a decade ago. Uh-huh. A decade ago, it really looked like the system could come under some fairly serious challenges. And now, at least for the time being, that seems to be off the table. So really, it's kind of a story of stasis, of program stability. So there hasn't been a huge development. And part of that is the what I call in the book the iconic status of healthcare in Canada, and it really is the third rail that if you touch it, you get electrocuted, and I think that the political sense of it. At least right now, but a major point in the book is that could change. That's been politically constructed, and that could be politically deconstructed.
Well, it sounds like you've almost answered the second question that folks had, which was sort of what direction are things moving in Canada? Is there movement towards expanding public coverage, or does it look like privatization is going on? And I know you had also mentioned in the book that there are some provinces who are sort of violating the Canadian Health Act, but it's not being entirely enforced. Is that still sort of the case, or?
Well, the interesting thing really about the Canadian Healthcare Act is that it really is very permissive. It allows a lot of things, and it allows things that no province has tried to undertake. Mm-hmm. So that speaks to the kind of political protection that the program has. So if I answer the question first about the sense of privatization, that's an ongoing debate in Canada. And part of it is related to the questions about what privatization means. So on the one hand, we probably have seen a shift of provision of services from some sort of independent, not-for-profit venues like hospitals, which are not publicly owned, but they're perceived as being public providers, to for-profit private providers, and yet those services are still being covered under public insurance. Right. And so, in a sense, there's privatization in service provision, but for most patients, they wouldn't notice the difference. There's no fee at the point of service. They don't get extra billed. They just go to a different venue to get service they might have in the past received in the hospital. Privatization also sometimes is taken to refer to the growth of private insurance. And while some provinces have done this, there's nothing in the Canadian, in the national legislation that prohibits private insurance. The issue, what it prohibits is using public money to subsidize private insurance. And so private insurance simply, even where it's been allowed, explicitly allowed, it really hasn't taken off because it doesn't make sense for most people to privately insure in a public system if the public system's running well. Right? So there's no, if there was I think a major failures in the public system where you would see it is in the growth of private insurance. And again, about 10 years ago, there was a court ruling that explicitly stated that banning private insurance was unconstitutional in Quebec. And people thought there'd be a huge growth in private insurance, and there really wasn't because there just wasn't demand there. So we haven't seen privatization in that sense. Privatization also sometimes is taken to mean the delisting of publicly covered services, so publicly funded insured services. That's happened a little bit at the margin, but not really, not in any significant way have the comprehensive set of health services that are insured been pared down. In some cases, there has been growth in types of services you might think would be treated as comprehensive. MRIs, where provinces haven't stepped in to fill that gap and cover those publicly. But that's really kind of at the margins of the system. Right. And so the final one, the privatization is sometimes taken to refer to, is the growth. As I said, the Canadian system's narrow but deep. So it's the growth in the importance of areas that don't have comprehensive universal public insurance, such as pharmaceuticals. That area has grown so much in terms of people's needs, in terms of the expenditures, and yet that's an area that doesn't have universal public insurance. And in that sense, the system is passively privatizing. That is, unless governments step in to fill that gap, it does become, in a sense, a more there's a higher level of people privately insurance or privately paying for those kinds of services. So privatization is a pretty mixed bag, but for most people, their experience of the core of what Canadians would call Medicare, there hasn't really been a fundamental change. And then if you turn to the question, which way does it seem to be moving? As I say, about 10 years ago, it might have looked like the idea of expanding those programs was less politically feasible. There seem to be challenges to the existing system. And I think that period is, at least for now, it's in abatement. And one of the things that I just read yesterday was a report card done by the Canadian Medical Association of the system, which finds that about 70% of Canadians, or at least survey respondents, responded that they would give the Canadian health services system as they experience it either an A or a B in terms of grades. 70% and basically a third would give it an A. And that hasn't statistically changed since 2010, which is an earlier time they reported, so a half decade ago. And I think with those levels of satisfaction, it makes it seem more likely that where there's perceived need, that there's the pressures are in favor of public expansion now. So it would be surprising to me if a universal national program for pharmaceutical care doesn't come at least back onto the political agenda at some point. And the same with long-term care, right? Because that's something a lot of people face and a lot of people worry about. So it does seem to me that if the system is moving in a direction, it's at least it seems to me to be politically more favorable to expansion than it has been in the past.
Yeah. So I guess you kind of just answered this question, but the next question was just about support or satisfaction of the of the public health insurance there. What is it currently? And I guess you kind of answered it by saying that it's sort of unmoved since the 70s, did you say? Or
Well, what I would say is probably since around 2000, say 2000 to 2005, there was a sense that healthcare costs were growing very quickly, and it was being politically constructed as if healthcare would grow to the point that it would overtake provincial budgets and squeeze out other things like education. That was the typical framing, and the argument was that healthcare, it's an insatiable need. You can spend as much as you want on it, and so if you don't have political control, and that was the argument, that it would grow higher than GDP, and I was skeptical of that argument even at that time. And I think lots of people were, and it just turned out not to be the case. There was growth, but it was growth in part by political choice that has now tapered off to being more or less comparable to GDP. So there's not that sense of pressure. And I think around that time, too, there was also some, I think, politically motivated efforts to try to create a sense that the system was failing. And that probably had some... impact. It probably did get some traction, and yet I look at those numbers, the satisfaction numbers now, and you just don't see that, and you just don't see the kind of recurrent media stories that were being propagated at that time about the failures in the system, which make good stories, but that's not my sense. And even then, what to me was most interesting is if you ask people what's your sense of the overall system. That could range from middling to okay, but if you ask them, what's your perception of the services you've received, it'd be a much higher level, much higher favorability rating. And people in Canada always wanted to explain why that difference is, though I don't think it's all that much of a surprise or a mystery that it was politically constructed, and we don't see that to the same degree in the current context, I don't think.
Whereas, ironically, here in the United States, healthcare costs are edging out education services and the other things, and it actually doesn't receive much coverage at all.
Yeah.
There was a question about a very specific part of your book, which is the moment where there's a federal tax increase, a 2% tax increase that you cite as sort of important for sort of securing buy-in for national medical insurance, that essentially these taxes are being paid so that there was provinces had to sort of buy into the system. So I think this is clear that, from the perspective of the U.S., even talking about taxes that's the third rail of the United States probably for some time. So the question was, why was there so little resistance to that tax increase, and what was the dynamics of how that helped sort of secure the Canadian Health Act?
Yeah, and just to clarify, I think so that the tax increase came in after the program had already been established and passed, and the legislation was in place. Really, what it did, so it wasn't key to the passage of the legislation, but what it was key to was ensuring that provinces didn't feel they could basically opt out, right, because they were paying such an explicit tax, a tax that everyone knew was there to fund medical coverage, that it would be untenable for a provincial government to say, well, we're going to let our citizens be taxed, but we're not going to get those benefits. And so that was, it wasn't that the tax was important in and of itself. It was important in forcing provinces into a politically unsustainable position that they would have to then accept the federal, sort of the federal deal. But on the general question of the raising taxes, and especially linking them, so it was linked for that reason. But I do think that had the benefit of attaching the tax to something that was politically popular, that people anticipated seeing real benefits for themselves personally, rather than if you have a general tax increase where people just feel that money's going into general revenues, and they often feel that it's going to someone else. this was a very clear example where people anticipated a benefit, and rightly so. And I think we're willing to. It made it politically more feasible. And the tax itself was part of a budget package, so it didn't have to be approved on its own. It had to be approved as part of the, I guess, what you would probably call in the U.S. an omnibus legislative package. But the other thing was that it was a national tax, and that really, and I know that you've talked in your summaries, and I spoke in the book about the concern about province-specific taxes, and it's not that national taxes aren't politically vulnerable. It's that provincial-specific taxes are even more vulnerable because they're always subject to the argument that we're putting our provincial businesses at a competitive disadvantage vis-a-vis other provinces. And so I think that at least that argument was dulled in this case. And the last thing I would say is I'm not insensitive to the fact that this was in a period before Proposition 13, before the real kind of anti-tax movement really took root. But it's important to remember, and I think this is a theme throughout the book, those kinds of the anti-tax sentiments that you would have seen in Proposition 13 and that grew up in the United States, they were growing here as well. And they were strong here as well, and it has created a different context than exists here than existed at that time. So, but that said, I know that you both made the point. One is that when you're spending a lot of money on private health care, you're spending the money as a society. You're spending the money anyway. And the other big issue about the single payer system is the savings in terms of administration. I mean, someone had raised the question about what the Canadian Medical Association and its sort of views on the system, and I think to some significant degree, physicians in Canada really have not just reconciled themselves to a publicly insured system, but they simply do not have the challenges of billing their patients. It changes the kind of business you do. That collections is not a major, billing and collections is not a major aspect of private physician practice. And it's important to remember in Canada, and I should have mentioned this when we talk about privatization. On the physician side, the Canadian system is privatized. That is, these are physicians work for themselves in small businesses for profit on either a fee-for-service or a fee-for-patient basis. But they're private practices, and they're for profit. And the Canadian hospitals in the main are, while they're typically not for profit, they're typically independent. They answer to a board of directors. They have various funding arrangements with the government, but they're not public in the sense of being owned outright by the government or run directly by governments. So it is a private system. Yet the upside on the doctor's side, if you're in a private for-profit business where you don't have to bill, or you bill and collect from a single entity that's pretty reliable about paying.
Right.
That's a very attractive proposition.
Yeah. No, thanks for this context that you provide around the 2% increase. I think that was that helps me to better understand how it could have passed.
Right.
Although it's still hard for Americans to understand how a tax increase, even when it does have proposed concrete benefits, it's still difficult to pass. It's not really an explanation for us about how something.
No.
And I just wanted to ask our next question: how did the Liberal minority government win over Conservatives?
Well, and that is an important difference, and that is that. Well, two things. in bringing the legislation, the Liberals were in a minority position. That is, they didn't command enough seats in the House of Commons on their own to get the legislation through. And in part, one explanation for why it went through was that they had to maintain the support of the New Democratic Party, which is a social democratic party and was favorable to that program. When they got to the period of the tax increase, which was there had just been an election, and at that point, the Liberals were back in, and they passed it as a budget, but they knew they weren't going to be going to an election for a long time. And so one of the differences between the systems is that, in a sense, you don't have to win over the Conservatives necessarily, or at least not at the federal level, because with strict party discipline, if the Conservative Party's not in power, they can vote against it, and that it doesn't change the outcome, because typically governments can get through what they want to get through. And even in a minority position, what it means is parties that, if parties were to vote against the legislation failed and caused an election, parties are very careful about going to an election, because for elected members, the only thing that can happen to you is you can lose your seat because you're already a member, right? So the system in that sense is a bit different. But I don't want, I wouldn't overplay that either. But where the dynamic really comes in the Canadian system is probably less in the House of Commons, that is in the federal parliament, but in how the national government interacted with conservative parties, or certainly neoliberal, free market kind of oriented parties in the provinces, because they did face that opposition. And so part of the issue was how they managed to get provincial governments on board that were actively at the time working to try to derail this. They knew, and so the answer in part comes back to political popularity. They knew people wanted something done. And so what they were doing was they were trying to create alternatives that preserved a greater room for individual, what they would use the language of individual choice, that is to self-insure, not insure, so voluntary insurance, but that would appear to be doing something to address some of the kinds of problems that were perceived among the public. And so I think it was largely that the Canadian public in general had a sense that something needed to be done, which allowed the federal government to engage with those conservative governments, and if not win them over, because in some cases they really may not have, and we still see that as late as a decade ago. It put them in a politically untenable position to resist, and certainly that's what happened in Alberta. They were not happy about the direction of the national program. They didn't want to see it, and 50 years later, they challenge it again, largely on the same sort of vein of ideological thinking. But again, in the face of public opinion that was just not receptive to the direction they were going to take it, and that was in 2008 to about 2010. And now that's just not on the radar, even in Alberta anymore.
Thanks. So the last question we have is about sort of the reception of your book. It was such a unique take on the history of health reform, both in the U.S. and in Canada. So what's your feeling of how the book was received? Did you get sort of pushback? How did other folks writing in this field react to it? And do you feel like it left a mark on the field?
Well, I feel more like it left a mark now that you guys are doing it.
Good.
Well, I think what happened, my sense of the reaction, certainly in academic circles, it got quite mixed reception, because of course it's, if you have a conventional wisdom, lots of people sign on to it. So, you're not just offering a criticism or an alternative view to one other author. It's perceived as being a criticism of typically kind of a group of people working in that area. So I did get pushback, but and that's what I expected, and I had hoped the book would generate that. To some degree, it was, I don't know if it's unfortunate, maybe it's fortunate that right around the time the book was published, the issue was dropping off the radar in Canada. And part of the intent of the book was to say proponents of universal public health insurance should not assume that we have it in Canada because it's natural or it's automatic or it's inevitable. And I had a sense that there was sort of a sense of hubris among supporters of universal public health insurance, that it just kind of existed here because it has to. It couldn't be any other way. And I think one of the main messages of the book was to say that level of support has been politically constructed, and as I said before, could be politically deconstructed or undone, and that it requires work and vigilance to ensure that the Canadian system would remain the way it was. Now we're in a period, sort of a hiatus, but at some point, these debates always come back, and so there will be political contestation over that again, or over expansion. But it did kind of fall off the radar a bit, and so the book, I think, just came at a time where 5 years earlier, I think the message would have had, more resonance. And yet in the United States, at the time I was writing, I had the sense that people thought, well, after 1992, 94, that this was all, this was off the radar for quite a long time. And I wrote somewhere in the book that, maybe not universal public health insurance, but that a major health insurance reform within one or two presidencies of when I was writing, which I think I probably penned those lines in 2005, would be imaginable. And there was. So I think there was more interest in the book in the U.S. And there the main message, which I hope people find compelling, I'm still convinced by it, is that for the same reasons that universal public health insurance in Canada is not automatic, inevitable, natural, I don't think its absence in the U.S. is automatic, inevitable, or natural either, and that it was, a confluence of how the various factors that could lead to such a program either managed to sort of piggyback on other factors, in Canada the territorial dynamics, or were derailed by other factors, and in the U.S. that was the race dynamics. In the period where it seemed plausible that a program could have been forthcoming. So I think the argument of the book really is about the importance of politics and political conjunctures and possibility, rather than inevitability and sort of an automaticity in terms of the kinds of programs that countries end up with.
Well, we started reading your book at a great time, because there's now this national, just having Bernie Sanders running in this election has created this massive national dialogue about national health reform that hasn't happened in a long time. So
yes, so it's encouraging that, and my sense of some of the earlier programs in the United States was the surprising length of time between when things come on the political agenda and the time it takes for them to come to fruition. I think in Canada that probably is a bit shorter. In healthcare maybe not necessarily, because it still was a long gestation period. But I think that I hope that people can remain positive, even if it seems that immediate gains, are challenging.
Yeah. Well, we're still in the movement, so we're all still hopeful.
Exactly.
So thanks for giving us hope, and also just this great piece of work. So And for joining
and
us.
for joining us.
And thank you very much for having me, and thank you very much for reading the book.
No problem.